Hi, and welcome to the Leader's Edge podcast. I'm Sandy Laycox, editor-in-chief of Leader's Edge. In this episode, I was honored to sit down with two giants in healthcare and policy, both former secretaries of Health and Human Services, Alex Azar, who served under President Donald Trump, and Donna Shalala, who served under President Bill Clinton. In a very lively discussion, we cover interoperability of electronic health records, creating guaranteed markets for life-saving drugs, whether there will ever be an end to fee-for-service, and what now for the ACA. Tune in.
Let's start with interoperability a little bit. So you've been working on that, for a long time. I used to work for Hospital Association, safety net hospitals who were trying to implement all of that. Yeah. It was very challenging for them. They were never on time meeting any of the standards. So I know it's moved forward some, but can you just talk a little bit about how we really get hospitals, and providers through true interoperability?
Well, so it's moved forward a lot. So what the progression was, Mike Levitt started us on that journey and said he wanted to bring a convening of all the players together and likened it to building a national railroad system. You need to figure out what the one gauge is, or you end up like Australia where they have two different gauges of railway. They literally have to transfer goods because they never developed that. What's the gauge? And so that interoperability tried to get going. That was less of a priority in the Obama administration with the stimulus monies. Mm-hmm. They funded a lot in terms of adoption.
Right.
And so what happened was you got the electrification of health records, but then balkanization. So it was a big advance because you got people thinking electronically.
So let me give you an example. The University of Miami Hospital is right next to the great public hospital, Jackson Memorial.
Yep.
They picked two different systems.
Right.
And they should have been systems that could have connected, but they weren't.
Right.
And so what I did was, now we're going to make it so they will connect. So that's the interoperability and information blocking standards. And I think one of our big accomplishments was we were able to get the major EHR vendors to effectively agree to that regulatory framework. Personal ownership of information, interoperability, no balkanization, and so there are timelines for implementation. It'll take time for that to happen, but I think we're on that path now. Mm-hmm. We actually will get to where you can show up at any provider and they should be able to get the core elements, the core data elements of your records.
The big government challenge was between the Defense Department and the VA.
Yeah. Right.
Because the Defense Department, when someone retired, couldn't get the records over.
Right.
They had to carry them over.
Yeah.
Well, I mean, I've told this. I've had the experience where I've been an inpatient at a hospital, an outpatient at their at a primary care doctor, and going to their CAT scan group. And at every single place, because they all three were on different medical record systems within the same integrated provider, had to go through my medical history, my medications. I literally got discharged from the hospital, went to get a CAT scan, and they did not have in the system the very meds I had been given on discharge because they were on different platforms within the same system.
Do you all feel that sort of the push by the big by the big tech like Apple and those for the fire, to find is that helping?
It is so and those are the standards that we put as part of the interoperability of those, and this is beyond my technical, but those fire standards, just whatever are the platforms that make it so that the technical people know how to create that integration is what needs to happen.
Yeah. So we're on the right track now. We just got to keep on the train.
I think we just need to go forward with implementation, and the Biden administration needs to enforce.
However, the effort by a bunch of those companies to try to develop a healthcare system, is they found out how complex the system was and what the multiple cultures were within the system. So in interoperability, you don't have to worry as much about culture as you have to worry about the technology to be able to do it.
Right.
And what we had to do was we had to make sure we respected that within those EHRs there is intellectual property. There are algorithms and there's important sort of intel inside beyond just the information. And that was really part of what we tried to do in the final rules was how do you respect what's sort of trade secret / intellectual property, but still allow the patient's information to move with them.
Transfer, right.
Yeah.
Do you all worry about cyber in this? I mean, it's
absolutely.
Is there any thoughts around solutions there, or sort of more regulation, more government models?
Did
I stump you all?
You've run a health system, so how do you think about how?
I think in fear.
You think in fear, yeah.
It's probably for any healthcare company that has health records, it rightly is right at the top of the board of directors list of enterprise risk management items, and that is probably more than government regulation. The most important thing that can happen is just that level of focus. And the problem is it gets down to the level of just like phishing training of your employees.
Right.
It really gets to that kind of level because you can't airlock your systems, or then they're not interoperable by definition.
Exactly. All right. Value-based payments. You guys talked about a decent amount up there. I have been interested in this, moving completely away from fee-for-service for a long time. I've been studying it and looking at it. So it looks like in the public payer Medicare, there's been a lot of movement. But how do we push this forward in the employer-sponsored system? What can employers do to really get some of that, risk transferred over to the provider side?
Well, employers have been playing around with ideas for a long time, and a number of the big employers have tried to do this. They usually need help, and that's why they go to the Aetnas and the big insurance companies to help them manage it. So they're self-employed, they're self-funded, but they go to United or to Aetna or to one of the big companies to try to get that value system going. Letting the patient have more choice. Most patients don't want more choice. They want a simple, straightforward system with a card that they can go in for. But I think that businesses have had a lot of experience in this area, and they've tried different things. Mostly they've been able to slow down their costs.
I think you've seen advances. For instance, Medicare Advantage with commercial payers, especially in Florida.
Yeah.
I think over 80% are in alternative payment arrangements. So they've been able to figure out there with providers alternative payment systems. A lot of employers and health plans are probably too small to engage in the transactions costs to set these up, or they don't have the leverage.
But the big employers have been able to do it.
They don't have the leverage with the providers who say, we'll take our fee for service, thank you very much, because they have so much power. That's where Medicare can be a guide by basically, with such pervasive market power, 40 to 50% of every market across the United States, that's where Medicare can really, as the dominant payer, make changes that ripple through the system. I mean, how many hospital contracts for private insurers right now say we'll pay 150% of Medicare fee for service?
Yeah,
it's a one-page contract. They free write off of Medicare. So if Medicare fixes it,
then it will
can ripple through.
I sat on the board of one of the major insurance companies, health insurance companies. Their prices were dictated not by their own analysis, but by Medicare.
Yeah.
Oh, really?
Oh, yeah. Most provider contracts are simply a percent of Medicare fee for service. Yeah.
Do you think we will ever get completely away from fee for service?
I do, actually. I think we're moving in that direction. Now, it's going to be a hybrid because they're going to look at the prices of individual services. But I actually think this Medicare Advantage movement, as long as we keep the money in it and keep it attractive and don't try to finance other things out of the overpayment, what I would describe as the overpayment of Medicare Advantage, we're going to get more reforms there.
Agree.
Okay. Let's talk about patient engagement. So let's say we get people all the data, it's clear, they can understand it. I am a little bit of a cynic like you and don't know that people will then use it to make different choices.
Or they can use it.
So how do we...
their employer will allow them to go shopping around as opposed to going to one place that they have a contract with.
Do you think there's ever going to be a place so employers now use sort of the carrot, right? For people to make good decisions. Are we ever going to get to the stick?
Yeah, so let me I do not actually believe one of the false impressions of trying to put the patient at the center of healthcare is this notion of casting the patient off as an atomized individual to study data and have to make choices like that. That is not actually the vision that I articulated was working towards. What I wanted to do was to empower the patient to be at the center, but with the helping hand of an incentive-aligned physician. Because as Secretary Shalala said, I think they want choice, but actually people will do what their doctors recommend most of the time. If their practice, whether it's primary care or otherwise, has an aligned incentive, that's why I believe in total cost of care, the aligned incentive of managing cost of care in a quality way, keeping them out of the hospital, out of the nursing home, they will generally go where they're guided by their physician. And so that helping hand, and so right there, you're putting a learned intermediary in there helping, and with financial incentives to actually study, and there are just a couple of core areas that are most of healthcare spending. It's going to an orthopedic surgeon. It's going to the highest quality, lowest cost orthopedic surgeon. Highest quality, lowest cost diagnostics. Ophthalmology can be another key area. Cardio can be another key area. Okay, so those are some areas where these practices can build relationships and networks of referral that are built on transparency and those aligned incentives. The patient doesn't have to be sitting there shopping, okay? Doesn't have to be going to Google or an Amazon tool to shop. Now, there are a small number of consumers who are rabid shoppers, and you see this in every space. You see that with grocery shopping, not to compare grocery shopping to healthcare, but you see it in terms of consumer behavior, that to drive and create efficient marketplaces of pricing with transparent information, a very small number of patients are sort of thought leaders that are very informed and drive, and the rest of us, the other 98% of us, sort of get the free ride off of their work.
But they have to have an insurance plan that allows them to do that.
Yeah, and that's where I think the plans, I think the employer clients and the plans, once this information is more available and they get to see it, they will start developing benefit packages that, whether carrot or stick, create. At some point, a plan and an employer are not going to want you to go to a $40,000 hip replacement that is lower quality than a $10,000 hip replacement.
Yeah, and the Medicare Advantage plans, I could take you to Miami, to Leon. Which has all Cuban clients, uses Medicare Advantage. They negotiate deep discounts for services with the hospitals.
This can be done.
Yeah. Do you think, you mentioned this up there, is Medicare Advantage going to take over Medicare?
Yes.
Yes.
So we wrote about Medicare Advantage a couple years ago because I didn't hear anybody talking about it.
The projection is that it'll be over 50% by 2030 by the CBO. I think it's moving faster than that.
Yeah.
Should employer plans be incorporating it more as options?
Oh, absolutely.
Absolutely.
Yeah.
If they want to contain costs.
Yeah. And if they want their employees to be happy.
And if they want to not have to cover dental and on separate plans,
Okay.
they can pick one that's more comprehensive.
Yeah. All right, just a couple more. I want to talk about drugs for a second. Not necessarily the cost, but you mentioned briefly about incentivizing drug companies, to work on vaccines or...
by guaranteeing markets.
Right, by guaranteeing markets. So we looked a year or so ago about antibiotic resistance and this huge, and that nobody's really talking about. And it was very scary. And one of the things we found in our interviewing was that there weren't incentives, drug companies weren't really incentivized to make more antibiotics.
Exactly.
In fact, it's the opposite. And this, if I had a second bite at the apple, this was going to be something I really focused on, which is you have the same market failure that you have with vaccines in antibiotic resistance. Because effectively what we need is for a drug companies to develop antibiotics that then sit on the shelf. Because if they develop a next generation antibiotic and it gets overused, you've just blown it again. You need to hold it in reserve. So that's basically a role for government there in making a market, buying it up, just like we do for pandemic flu supplies, just like with COVID vaccine.
And for children's
vaccines. Because that's what the problem you have to solve.
Now this gets the government making markets with its priorities. So I think COVID has moved us beyond. We've always guaranteed a market for specific things, whether it was AIDS or other things. But the COVID thing moved us so dramatically into a relationship with the major drug companies that it may define the future on a set of things like the antibacterial.
Yeah.
And I think, it was in part because of having someone with my background there that we were able to break through, I think, traditional Republican notions of not interfering in the private sector, because I assess these as economic problems. And where there's a market failure, there's a role for government solving that. We saw this in 2005 when I worked with Secretary Leavitt and President Bush to create the pandemic flu plan. It was a mini Manhattan project, just the same, which was we had just had the Chiron manufacturing failure in Liverpool. So remember, we had a shortage in 2004 of flu vaccine. We needed more domestic manufacturing, more egg-based production, and we needed to convert the industry to cell-based production, and we needed to create a guaranteed reserve so they would produce enough each year so we had surplus capacity to run a second pandemic flu strain run in our system. That wasn't going to happen just relying on market forces. We had to basically fund that, and that was President Bush's pandemic flu plan, which was really industrial engineering on a small scale that then I took in warp speed and just blew that out. A very similar concept, though, of this public-private partnership.
But one of the companies didn't take the money.
You're talking Pfizer?
Yeah.
Well, Pfizer did take the money because they took a $2 billion guarantee.
Yes, they did it the other way.
I would work with companies, whatever solved their leadership's risk aversion challenges.
They didn't have a cash flow problem. They needed the guarantee of the market.
Yeah, Pfizer didn't need the capital, the working capital or capital to do it, but they needed to know that if this went away, I still was on the hook to buy $2 billion worth of vaccine.
Right.
Now the question is, whether the approach in the future will be the guarantee of market, whether that'll be more bipartisan because Republicans will not have Alex Azar sitting there, or whether you'll have to fund up front the cash flow for the development.
And my view is I took them where they were, solved their problem. Okay, if you don't need funding to build a factory, then fine. You need a guarantee purchase, fine. I think you need to meet these entities where they are and solve their economic problems.
That's the importance of understanding the culture of the industry.
That's a really good point.
It's a similar issue, frankly, with the strategic national stockpile and distribution. So, for instance, I believe what we need is to basically fund the strategic stockpile. If we really want a stockpile that's about the ability to supply pandemic supplies as a surge for the whole country, which is not actually, I think you started the National Pharmaceutical Stockpile, didn't you? So when Secretary Shalala started it was called the National Pharmaceutical Stockpile, which is you keep some of these bioterrorism chemical countermeasures in secret locations that only the government would buy, like anthrax vaccine. Okay? That got bigger as we got more countermeasures. We had some things like N95 respirators and field medical shelters, hospital units, as surge for if we had a hurricane or tornado or a nuclear event in a localized area. It was never meant to replace the whole distribution system. And so the question becomes, is the solution that you just put in these secret warehouses massive amounts of supplies that will expire? The other idea, this was strategic stockpile 2.0 that I was trying to put forward, is we have a very developed wholesale distribution system, but it runs on very efficient just-in-time inventory. Do we solve their business problem? There is a number at which we can financially pay for their working capital needs to hold excess inventory beyond what's economically rational and have them do that.
What I would have done is taken the VA hospitals and actually give them the storage capacity and let them use the supplies, and therefore you'd have them up to date, but they would have had the storage capacity, but they would have kept using it, then you would have just kept filling in.
So it wouldn't be expiring.
Whereas for me, I'd instead of that, I would just say to the McKessons, Amerisources, et cetera, of the wholesale distribution system, we will pay you for vendor-managed inventory to keep afloat excess beyond what's economically rational for you.
See, I would have given the float to the VA and maybe to the military hospitals too, but I would have used the government hospitals with a float.
And hence you see the difference between Democrat and Republican.
But we would have gone in the same direction.
But you would have solved it.
We would have solved the problem.
So do you think there's will to, or, are they thinking about this currently in the imminent? Do you think they'll be working on this?
On which issue?
On
the
this,
stockpile?
on the vaccine?
Yeah, it's actually in the current infrastructure bill, but I think it actually goes more in the old style direction of just adding more to warehouses, I believe, with domestic production where they'll pay a supplement for domestic. I think that's where it is at the moment.
Mm-hmm. Though the appropriators are very interested in this. Oh. But the overall strategy is being worked on by the people in the White House, the COVID people, and the people at HHS. But right now they're doing some temporary fixes.
Here's what worries me about pandemic or other kinds of emergency stockpiles is during and in the aftermath of an emergency, you have a lot of bipartisan consensus to fund things.
Right.
5 years from now, when it becomes a choice of low-income heating funding for an appropriator versus N95 respirators sitting in a warehouse, and there's a limit of money.
Yeah.
I just don't think we're ever going to be completely through the pandemic, and I actually think that the bipartisan consensus is going to continue. But we need a structure that we've agreed upon.
She's more optimistic than I. At least
she just said the pandemic's never going to end.
But on the funding issues, yeah.
So
I think they're very fickle.
I watch the appropriators.
Well, and you mentioned that in there, that they're always really able to work on stuff and get it done. Yeah.
And now the chair of appropriations in the House has always had the HHS portfolio. So she understands a lot of these issues.
Is there political will to make the fixes to the ACA on both sides of the aisle that would just make it finally like the complete, really useful law that it could be? Well, they made some of the changes because they put some of the subsidies in already. Whether reconciliation will do any more, they're going to do some things in the appropriations as well. They're going to eat away at this. Eat away at it.
Yeah. And they've got to figure out some incentive to get states like Florida to expand their Medicaid program.
Right.
So they're going to offer them again 100%, but I don't think the governor's going to do it.
No.
I think a lot of Republicans, so in the past, some of the fixes that would have made a lot of sense, like moving community rating from 3-to-1 to 5-to-1 to create a more rational pricing structure to incentivize people in. Those changes that Republicans would have supported as kind of rifle shot fixes couldn't be done because it violated the notion of repeal and replace
exactly
as a whole. So I think the question now becomes, can those fixes happen, or is the Democratic price tag of what the Christmas tree of what gets added unpalatable to Republicans? So that just becomes a negotiation of, can you count to 60?
And that's why I think it has to be done in appropriations.
Yep.
That was Alex Azar and Donna Shalala. I hope you enjoyed it. Find the rest of our series at SoundCloud, Apple Podcasts, and Spotify, or leadersedge.com.